totally worked. So I'm going to do a couple talks for you guys today. The first one is just over some of the CPT coding changes. Now, I got home late last night, and my 2020 CPT coding changes book came in the mail. So if I go over a code that you want to ask me some questions about, I have the book up here, the rationales up here. But I think you're going to find that most of the stuff that's changing in 2020 won't impact you. But because I think you're getting 4 CEUs, we kind of have to go over it. So what I'll try to do is explain to you, what this technology. Just stop. Not connected to GoToMeeting audio. All right, well, it's going to be hit and miss. They don't have internet in this building. Can you believe it? So, it's a bank. They're all millionaires. And so what's happening here is I'm looking at the screen. The audio is going in and out. So, but she didn't ask me to record it wonderfully. She just asked me to record it. And I'm married, so I know that I just need to do it. Shut up. So I'm just going to shut up. We'll talk about some big changes first. Biggest thing for 2020 in Medicare's world was getting us ready for all the coding changes to E&M codes in 2021. Now, you don't care about that, because you don't pick the codes usually. Your doctors do. But I'm going to go over those changes with you. I'll start with a couple little things first and tell you a little bit about what's going to happen, because E&Ms are the most common thing we bill every day. So you'll probably want to know a little bit about that. And then after we finish this first talk, we'll take a break, and then we'll come back and I'll go into more detail about the E&M documentation requirements. We'll talk about some codes that are changing in the surgery section. Most of the radiology stuff is institutional radiology changes, CTs, some new spec codes, barium enemas, things that you don't do in your office, GI codes. They might be things that you order, but they're not going to be things that impact you. No pathology changes that I'm going to go over, and then there's a couple physical therapy. There's a new physical therapy code and a new code for dry needle injections. But the 2020 stuff is just not that exciting. So I total into this is the last year that I'm going to do I'm going to do coding updates. There's no big changes ever. And if there is something big, I might just do a 30-minute talk on something significant next year. But it seems like a waste of time I could go through this in 15 minutes for the people who are in this room. But let's drag it out. I did drive here. One of the things that we talk about, and one of the reasons that I think you guys should use Linda as much as you possibly can, is the days of making any money off of E&M coding are pretty much gone. Doctors sit around every year. Oh, and let me just kind of forewarn you, the first 4 or 5 slides probably aren't in your handout, so I should have told you that. I'm constantly updating stuff, and I tried. My new rule for 2019 was to stay 2 weeks ahead of my calendar, because I'm booked a year or 2 in advance. So some of this stuff I sent to Shannon like 2 or 3 weeks ago. But then I'm a nerd, so I'll read something new and I'll throw it in the presentation, and you don't have that handout. So in fact, Shannon's right now making copies for the next talk because I upgraded one of your handouts to be better. So this is more better information. So can you imagine? Ain't nobody in this room 2 weeks ahead of schedule. You got a stack of work there now that's 2 weeks old, and it's just going to get 4 hours older when you get back. So don't judge me just because I'm on it. So the reason that I want to talk to you about this is because the conversion factor is only going up 5 cents next year. So you get a whopping 5 cent raise if you're a doctor. Can you imagine? This is one of the reasons that doctors are selling their practice or joining Piedmont or Privia, because can you imagine if you go to work all the time and every year you're just getting cuts in your salary, that would be really depressing, right? So Linda hopefully is trying to help you with your contracts and credentialing to try to make sure that you guys are staying ahead of the game. Is anybody here in an ACO or clinically integrated network, an accountable care organization? You know, we talk about that because those are the folks who kind of help you with, I got to say this, you know, since we were here last time and we talked about boomers and Xers and everything, you know, the new insult for people like me, what young people do is they call everybody a boomer now. I'm a Gen Xer. Let me just get this straight. But she's sitting here and she asked, you know, we went into this conversation about how to treat Ys and Xs and millennials. And now that's all my son calls me, a boomer. Because if I say something old and fuddy-duddy, he goes, Dad, you're such a boomer. And I'm like, I'm not a boomer. Boomers are much older than me. Only she would laugh at that, though, so you don't really care. But I'm a little loopy because I'm still tired. But the conversion factor is not, you know, going up that much. So really, one of the only ways that you're able to make additional money in this business is through your Medicare managed care incentive plans, things like that. So anytime United Healthcare or Blue Cross comes to your office and tries to help you get involved with one of their plans, if you have the time, that's really it, because getting a 5-cent raise every year just ain't going to cut it. It doesn't help. In CPT world, one of the significant changes where we thought with E&M codes, Medicare, let's just start with the beginning because I got some time here. The coding guidelines that your doctors use for 99212, 213 came out in 92. That's when I got my job. So my first job was teaching those codes to your doctors and how to document. I'm having an email conversation with somebody this morning about this, and just so aggravating about these codes. Now, Medicare has been wanting to change them under the current administration because doctors are losing their minds about how much you have to document, you know, for the history and exam. And I mean, if you go to the doctor yourself, I mean, your doctor's spending 15 or 20, they spend more time noting on you than they do seeing you. I go to a psychiatrist, a nephrologist, and an internist. So I'm like a professional understander of what happens, you know. And my internist is really good. She actually touches me without disgust. But my nephrologist, he doesn't touch me, and he tries to build really high codes all the time. And I'm like, I'm not going to argue with him. He doesn't document that much, but he never even looks at me. He goes into the room and he's typing the whole time. My internist looks at my notes before she comes in because I see her in the hallway. She comes in, talks to me, and then she goes out in the hallway and types up the notes. One of the things you're going to find out is Medicare wants to change that, believe it or not. But they couldn't get the AMA to change the documentation guidelines. So in order to force their hands, what Medicare did was they came up with this system that said, listen, if you bill a level 2, 3, or 4, we're just going to pay you one rate, regardless of what level of service you bill. And the AMA was like, well, if you do that, that kind of takes us out of the loop. Doctors won't need to buy our books anymore, right? So the AMA acquiesced to the threat of Medicare. And as a result, the American Medical Association has already written the E&M coding guidelines for the 2021 CPT book. They came out about 3 months ago. Medicare looked at the rules and said, all right, so instead of getting paid one rate, which was called the blended model for levels 2, 3, 4, they're going to stick with 5 established patient codes that you know, 1112, 13, 14, 15, and 4 new patient codes. They're just getting rid of 99201. So there'll still be E&M codes. Now, the catch for you is you'll have to know the rules for the office visits, but the hospital visit rules are staying the same. So there'll be 2 sets of rules. But again, if you're a coder, it doesn't really matter unless you're the coder who's picking the E&M codes, right? So we're going to talk more about that after this talk. Other good news is that Medicare has agreed in 2021 to increase the reimbursement for office-based codes. So the American Academy of Family Practice is guaranteeing that if you're in internal medicine, general practice, or family practice, you're going to get a guaranteed 12% raise in 2021 from Medicare. Now, who here is in primary care? You get a huge raise in 2021. A huge raise with a lot less documentation. The other good news is there's going to be an add-on code if you're in primary care that you'll bill with your office visit. It'll be a G code probably. And that G code will pay you an extra $15 or $20. Now, right now, they haven't told us what that code's going to be because it's 13 months away. We won't probably know until November of next year. But this add-on code for primary care will be for family practice, general medicine, and internal medicine. Now, they wrote that, and then some other specialist got upset. It's not fair. What about me? So then Medicare came back and said, all right, we'll have a second code for non-procedural specialties like endo, rheumatology, hemoc, urology, neurology, OB, allergy, otolaryngology, ENT for those of you who don't know. Pain management, cardio, neph, and infectious disease, psychiatric, and pulmonary. Anybody here in those specialties? Yeah. So you'll get not only a raise for your standard office visit, but you'll have an add-on code for your additional office visit money. So you'll get huge raises in 2021. Good news, right? The other thing that happened in this year's what we call the Federal Register, the final rule, a lot of you probably know that, but nerds like me wait until the first week in November, and the government publishes this 2,500-page document that tells us everything we need to know about Medicare. And there's usually about 300 pages of it that deal with what we do, you and me and everybody else. One of the things that they allowed us to do last year was to reduce the documentation requirements, was that if a doctor could let his nurse or her nurse document the history of the present illness, and that had never been around before. Nurses were never allowed to write in the note why you were coming in. Everybody broke that rule, so don't look shocked. You never got caught until you got caught doing it. But Medicare made it official for this year that anybody could write in that note in your staff, as long as the doctor wrote, I have reviewed and agreed with the findings. And typically that's done at the bottom of the note anyway, because if the doctor signs off on the note, they're agreeing to everything the nurse has done. But this year for 2020, they've expanded that. And again, it's another rule that you're violating every day, so don't panic. But a lot of you have medical students in your office, you have nurse practitioner students, and technically we were never allowed to use their documentation to support our level of service. But Medicare is expanding that now to even include residents, nurse practitioner students, medical students. So that's kind of good. So this is called the Reduction in the Administrative Burden of Practicing Medicine Act. And it's all put together because people were complaining during the last administration that documentation was just out of control, especially with electronic medical records. So whoever was going to become president, whether it was President Trump or Secretary Hillary Clinton, the AMA petitioned whoever, you got to change these documentation rules. So CMS listened, and it just happened to happen under President Trump. So these are great ideas, I'm sure you'll hear him say. We did great things. But you don't know who I support yet, do you? See, because I'm not political. Another thing that's probably not in your handout, or it might be, I'm not sure, is the other big pain in the buttocks We're in that PowerPoint slide. You guys haven't missed anything. Other than me telling you there's not a lot of changes, and I'm going to drag this out for at least an hour. The quality payment program, if you're not in an accountable care organization, remember you still have to do this crazy crap, right? What makes the QPP program not fair is that if you do everything right, let's just talk about me, okay? If I take the trash out on Wednesday night, if I clean up my dishes, if I do her laundry and I hang it up, these are all things that I do. If I feed the cats and dogs in the morning, keep the house spotless, do all those things, but God forbid she walks home and finds one thing wrong, I get in a lot of trouble, right? That's what the QPP program is. You know, you do everything right and you can still get in trouble. Now, what makes this system inherently unfair, like my marriage, is that if I do everything right, there's a chance the government dangles, oh, we're going to give you this 8% raise. They dangle it. But in reality, it's budget neutral, so it only ends up being maybe 1%. But if I do one thing wrong, they take away 8%. Yeah. The system's not fair. So you have to work extra. You're not working, listen, you don't work hard to get a big raise. You have to work hard not to get the big kick in the butt. Now, every year, CMS monitors your quality measures, your performance measures, your improvement activities, your EMR measures, by assigning a specific point value. Now, in 2020, the points are the same. If you're not in an accountable care organization, you still have to go out and do all of your measures, all of your information on your own. All right? And look what happened. In order to avoid, it's like in the old days, when this first started, you only needed 3 points to not get in trouble. Now it's up to 45. And in 2021, it's going up to 60. So the government's doing this to encourage you to join an alternative payment methodology, which is an ACO. And or you're going to have to kick your butt into gear and learn all the rules about this. Now, I used to be able to come here and it was fairly simple. But I wanted to show you a couple resources that you have in the interim in order to do this on your own. The first one is still what I always showed you, qpp.cms.gov. It's a great website, and we'll go there as soon as Cox Media allows us to. They're lightning fast internet here in the bunker in the bank. And the reason I want to go here is they have, for small rural practices like you guys, because yes, believe it or not, this is not a metropolitan area. They have resources for you. And I'm not picking on you. I live in the boondocks in Martinez, Georgia. So that's why my son couldn't wait to move to Atlanta. And he went to a map of Atlanta and said, I want to move into the middle of Atlanta, and decided to move into Midtown Atlanta. Here we go to MIPS. This is if you're doing things on your own, right? Which a lot of you are. Now, the first thing that you should do when you go to MIPS is if you have an electronic medical record, make sure that you contact your vendor, probably around March. They're going to be able to help you with some of these, get you in some programs. But if you don't know, here are the 4 different methodologies, the 4 different areas that you get credit for. If you click on the quality measures, you can enter your specialty down here at the bottom. And the first thing that you want to do is, if you explore the measures, you can go in here and pick your specialty measure set and say, well, I'm gastro. And there's 268 measures. You want to do all measures. Collection types, you want to get familiar with your with the different methodologies that you have to report. I have some groups who use web interface, but you'll need to understand how this works. No measures there. Let's just do all. And there are 17 measures for gastro. And you want to do as many of these as you can. Normally people try to do anywhere from, 9 or more, so that your best ones are the ones that are going to get reported at the end of the year. If you need help, under About, there is a Help and Support tab where they have videos, webinars, online courses. If you go to About and you click on Small, Underserved, and Rural Practices, I'm going to give you a way to contact them. In Georgia, the federal government has set up Alliant, the Georgia Medical Care Foundation, and their website's on the screen, qppsurs.alliantquality.org. You might want to write that down or take a picture of it. You can't, it's too small.
Yeah.
QPP, I'll read it out for you. QPP SURS at Alliant Quality, one word, ALLIANT quality.org. You can reach out to them. The federal government gives them grants to help you. You can also call the QPP hotline yourself, which is 1-866-288-8292. Well, Steve, why don't you teach us this? Because my clients are large hospital systems now, and they have people who do this. So I'm lazy. And I don't like to learn stuff that I'm not going to need in my life. I just don't. But what I do with this is, if I have a question for like one of my practices, I'll probably learn enough about this to be dangerous. But traditionally, is anybody here not have an EMR? You all have an EMR? Okay. So if you have an EMR, your quality measures will be simple. You'll load those into your system like you already have. Your promoting interoperability will be done by your EMR vendor. They'll make sure that your EMR is up to date with all the qualities that are needed for an EMR. You can't control your cost measures. Your cost measures are things like if you do total knee arthroplasties, cataract surgery, colonoscopies, they look at the cost associated with your patients compared to national averages. So there's really not much you can do about that if you're on your own. And the improvement activities are just traditionally when you have, it's the smallest percentage of your overall score. So I don't lose a lot of sleep over it. But basically, you want to do 2 high-weighted activities, 1 high or 2 mediums or 4 mediums. And these are things where I've told you in the past, you can get like a high school student to pick some of these, or a college student at a local university, and they're going to do a couple little studies for you, and then you'll submit through the Medicare portal that you've done these things. And in the past, they were things like, I did a patient satisfaction survey. We have a Coumadin clinic, and we have a policy and procedure that we follow for that Coumadin clinic. Some of these, what I wanted to tell you about these, if you're listening, is when you call your EMR vendor, some of these improvement activities, you can get in registries, like through GRITs. Some of your EMRs will have these, so you can call your EMR vendor at the beginning of the year and say, this, you ready? I need to load as many quality measures as I can in my EMR, and I need to find out what improvement activities are available to me through my EMR, okay? And then I also need to make sure that you are certifying my EMR for my 2020 MIPS, and that's called your promoting interoperability. Okay, so your EMR vendor does this, not Steve. And if you have questions about it, you just go to About, and God forbid you work on a weekend. Right? I know. That's how I get out of doing. My wife started doing half marathons. She dragged me to Disney for 3 days, and my Apple Watch broke. No, it didn't. There was one day we did 12 miles. That's how. I lost a lot of weight on this last trip. Not a lot of weight, but when you're fat, 2 pounds is like 100. And then we came back Friday night, and that ding-dong got up and ran a half marathon on Saturday. And then she goes, do you want to do a fight? No, I don't. Not this Saturday. I'm so backed up in work. So I sit up in my new office that I did because the kids moved out, and I'm so happy now. Does anybody here have an empty house now with your kids are all moved out? Everybody told me that I would have empty nest. No. I am so happy. My daughter just got engaged, and I'm so happy. So anyway, I will be home Saturday working. You might have to take a Saturday, watch a couple videos. Another great resource for you before you panic about QPP is in the past you might have blown it off, right? But remember, it runs 2 years behind. So everything you're doing now is going to impact you in a couple years. So even if you join, the one thing is, if an ACO comes to your office, instead of doing 6 measures that might pertain to you, you're going to end up doing 15 or 20 that don't, which is fine, but they take care of a lot of this behind the scenes for you. But you can do it on your own. Go to your specialty society. Your specialty society will also have information on the best way for you to do your MIPS reporting. But it's not unobtainable. It's not something you can't figure out on your own in a couple hours. I go to Sandersville next Friday. They don't have an EMR, and I literally can probably sit down in a couple hours and figure out what the 2020 rules are going to be. It's not that hard. And it's not because I'm smart. I'm dumb. It's just I'll block everything out. Shut your door at the office. Tell them you're at a funeral. I don't care. Sometimes that's the only way people will leave you alone is if you don't come into work. I did the talk yesterday, and oh my God, Linda, it was 8 hours. I talked for 8 hours. And every break, I was like, all right, we're going to take a break now because somebody can't find the toilet paper. They're calling you right now. Somebody can't find a light bulb because we're the billing people, right? We know where everything is. They can't function. Right now, somebody's EMR went down, probably getting texted. But that's the QPP. You still have time to get it together, a little bit of it together. But if you haven't done anything, you're going to get penalized in a couple years. There's your QPP help. I gave you that, and I gave you their phone number. It's the best CMS website ever, and they have the best help desk ever. When you call them with a question, they'll not only answer it, but they'll send you the answer in an email. You could call them up and say, hey, listen, I'm internal medicine. I have eClinical Works. How many measures do I have to do, and what's my best option? And they'll tell you. Now, we'll go to the 2020 coding changes. There were 394 changes this year. There might be 4 that impact anybody in this room. 248 new codes, 71 deletions, 75 revisions. There's going to be stuff that you're going to see for the first time that I'm going to talk to you about because your doctors are going to think they're the greatest thing in the world. But you have to just say, no, we're not going to do this. Are you ridiculous? Well, why didn't you girls tell me about this code and this? Because it's ridiculous. The biggest thing that your doctors are going to hear about is online digital services or e-visits. Somebody at the AMA thinks that your doctor, instead of having a patient come in and making $85, is going to treat them over the secure portal. Now, if your doctor does this, let me know. But essentially, you would have to communicate with your doctor over the portal. Your doctor would have to total up all the conversations that they had over the period of 7 days. Now, maybe your doctor does. Maybe your doctor's a texter, but texting doesn't matter. It's not texting. It all has to be on your secure portal. Now, the only time I communicate through the portal is if my doctor, she increased one of my medicines. And she said, okay, send me a secure message if you're having any problems with it. But I don't communicate with her over that. If I have if I need to talk to her, what do? I make an appointment. But your doctors are going to hear about this code 99421, 99422, and 99423. And they're based on minutes. They're E&M codes, so guess what? There's going to be co-pays, co-insurance, deductibles. So you know who that impacts? You. I just sent him some instant messages. It's like last year when those codes came out for if the doctor sends a picture, if a patient sends you a picture. None of that stuff. But your doctors get all excited. Something new. But I would just not even, you can mention it to them. If they say, hey, what'd you learn at the meeting today? There's some codes that came out that you're probably going to hear about that we're just not going to, we can't do them. We just can't do them. Now, Medicare got all upset at those codes. And Medicare said, well, if you want, we'll pay for the 994 codes for a doctor. But if it's a nurse practitioner or a PA, we got G codes. Now, you can attest to this. I was just at your office on Monday. Mid-levels don't know nothing. They don't know what kind of insurance patients have. They don't know anything. They're just there. Give me my $100,000 a year. I'll try to not kill anybody. And so you can't expect that a mid-level is going to know. I can't bill 99421. I got to bill G2061. Again, there's going to be a co-insurance, deductibles. Medicare hasn't published their policy, but it'll probably be something like you have to get the patient's approval before you do this. Like those other two codes, you had to get their permission. Say, hey, listen, do I have your consent, to do this? So again, we're going to read about it. And listen, here's another thing I always tell you. You're going to get emails. Hey, for $400, you can join our coding conference hotline and find out all the new E&M coding changes don't do it. There's nothing to talk about. I'm really going to drag this out for an hour. And I really look at this stuff. So here's another one that you might consider using, but no way. Nobody's going to. It's a new code. There's two codes for blood pressure monitoring. 99473 is for patient education and calibrating the device. First of all, we don't know what the devices are. But 99474 is for collecting data, blood pressure data, by a patient. And we're going to send the average systolic and diastolic pressures to the physician or mid-level. Medicare will pay for it, probably about the same as they pay for your Coumadin checks, your $18 or $19 Coumadin checks. But here's the catch. Here's what the code describes. Self-measured blood pressure using a device validated for clinical accuracy. Separate self-reporting measurements of, 2 readings, 1 minute apart, twice a day over a 30-day period, minimum of 12 readings. Collection of data reported by the patient or caregiver to the physician or other qualified healthcare professional with a report of average systolic and diastolic pressures and subsequent communication of a treatment plan to the patient. How about what doctors have been doing for years? All right, like I went in and my blood pressure was high, which was weird because I'm fat, but I'm pretty compliant with all my conditions. And my nephrologist looked at my cankles and said, dude, you're retaining water. So he put me on, I have ankles now, but I had a lot of swelling. I had a lot of edema in my legs. I didn't know that. I was figuring, man, my legs are really my ankles are looking fatter than normal. But I don't look at my feet, you know. But now I have ankles again, right? So my doctor said, listen, your blood pressure's up because you're retaining water. I'm going to put you on this diuretic. Go to Walmart, buy a blood pressure monitor, and if your blood pressure is not better in a couple of weeks, call me. Yeah, that's what doctors do. Your blood pressure is not better in a couple. So there's no way that Dr. Brazina is going to have the time, or I am going to have the energy. Or I check my blood pressure like twice that 2-week period. I mean, now doesn't mean you can't do it, but look at those codes. The time you might use those codes. Does anybody here do chronic care management on patients? Chronic care management. No. So, I mean, if you had a patient and you were billing chronic care management and they had a caregiver or something, this might be reasonable, but I just don't see this happening. Again, your doctors are going to hear about it. It's okay. You can yawn out loud. But I was really impressed with you. Did you see what you just did? Did you do that in school a lot? You do it in church?
I do when I work out.
Oh, man. Oh, my God, no. I thought it was awesome. It's really, it's not insulting to me to see people yawn. This is boring stuff. I teach Sunday school, you know. My new church Sunday school starts at 9:30, though. So normally people are awake at 9:30. So it's still early here. There's no changes to ambulatory blood pressure monitoring other than there's a little, right? So behavioral health. Anybody here in psychiatry? See, we could skip it, but I got to stretch it out. There are going to be times in your life, hopefully never, you know, God forbid, where you get a devastating diagnosis. And one of the things that the oncologist might do is refer you to a behavioral health specialist to try to analyze, you know, like if you're in end-stage renal disease or you're end-stage cancer. So they have a set of codes for behavioral health that are in your CPT book. And they deleted a couple of them and made them 15 minutes instead of longer codes. Not that you'll ever use these, but again, I have to kind of talk about them. Behavioral health assessments and interventional services. I just want to read this to you. Health behavior assessment and intervention are used to identify and address the psychological, behavioral, emotional, cognitive, and interpersonal factors important to the assessment, treatment, or management of physical health problems. The patient's primary diagnosis must be physical in nature, and the focus of the assessment and intervention is on factors complicating the medical conditions and treatments. I work with behavioral health specialists. I don't have any clients who've ever billed these things. But I have seen in audits people who have medical conditions where they'll go to behaviorists to kind of try to cope with those things. And that's what this is dealing with. And of course, they're going to have codes for individuals, groups, family with the patient, and family without the patient. So if you've ever went through something like this in your own personal life, this might have been something that would have benefited you. So the reason I'm showing it to you is that you need to know that there is reimbursement for families that are dealing with individuals who have health conditions that might be terminal, and you should seek out help in those areas. The biggest change in CPT this year, is there anybody in neurology here? Neurology. See, we could skip it, but I got to drag it out. The biggest change in the CPT this year where they changed all the EEG codes. Not the ones that we would normally be used to, not the ones that your neurologist does, but the ones. Is that a Jolly Rancher? Linda does Jolly Ranchers, and I can't believe she does Jolly. You're the only person who, has anybody had a Jolly Rancher this morning? That is the worst candy in the world. Jolly Ranchers are the worst.
You are not from here.
I am not from the South. I'm just telling you, Jolly Ranchers are the worst.
It's like a peach.
When I worked at my last church, we went to a mega church, and I worked the front door, and sometimes I'd work the door when you'd leave, and we'd have these buckets of candy, and people would pick through my mints to get to the Jolly Ranchers, and I would be like, oh my God.
Watermelon.
Oh, whatever. Okay. Too sticky. Electroencephalogram, I guess is what they call that thing. And there's a picture of it. They put some glue, and when I had mine done, they put some glue in my hair. And my dad had epilepsy, and they wanted to test me for epilepsy. That's normally what this is. I went in the morning. You try to sleep during the day, and they just measure the activity of your brain. Mine always came back as negative. No brain activity. The only code that we might be using in our private practices is 95813. That used to say greater than an hour. Now it just reads 61 to 119 minutes. But what they basically did was try to break these up into technologist codes, because it's like a sleep study. There's a technologist, there's a technical component for the equipment, and a professional component for the reading. CPT 2020 just deleted all the all-night codes, 95827 and seizure localization codes. They just rewrote that section. So if you ever get a job in neurology, you'll need to know that. But most of us, my neurologists don't use any of these codes in their office. These would all be facility-based EEGs. Does anybody here watch Botched? Botched? Did you see Big Booty Problems last week? Oh my, didn't you feel bad for that girl? You're going to have to amputate my booty? Well, this is a little bit about that. There is a new set of codes four new codes for grafting of your own fat harvested by liposuction. Now, so a lot of times what will happen is people will have their fat sucked out of their abdomen and then used as filler for their face. And that's why if you watched any of the Real Housewives, they always kind of, I guess to get rid of wrinkles, you can inject fat and stuff, or to fill in holes in your face. But just to kind of show you how it works, because that's what I do. When I do coding updates, I have to learn about this stuff that I don't know, because I don't need no plastic surgeon. It's hard keeping this together, but it's doing all right. I tell my wife I'm fat, but I have hair. I'm just real happy about it. I wouldn't want to be fat and bald, but I have good hair still. I found a new hair conditioner and shampoo that has collagen in it. It's purple. It's in a purple bottle at Walmart. You don't care, but if you have dry, thin, gray hair, I don't want to look at anybody. But go to Walmart and get the purple bottle. It has collagen in it. Now watch what they do. They suck out the fat. Any plastic surgeons here? They suck out your fat. They process it. They put it in a centrifuge, and then they can inject it into your face. And that's called AFG, I can't ever say that word, autologous fat grafting. Autologous means it comes from you. So there's allografts, autolografts. Would that be right, autolografts? Oh, okay. So, yeah, that's how it works, just in case you wanted to know. Dry needling. Some people can't, for trigger points, some people can't tolerate, I guess, the medicine. So there's this it's not acupuncture, which we're going to find out is based on Chinese medicine. This is still Western medicine, but they have commercials in Augusta for dry needling. So they came out with a couple new codes for dry needling, 20560 and 20561. I did a little research on it because I normally don't have providers in these. It says muscular tension and spasms can be difficult to live with. Herniated disc, nerve irritations, neuropathy, arthritis, With trigger point dry needling, TDN, the needle itself the needle itself and its effect on the tissue and the treatment. Very small needle, delivers no medication. When the needle is injected, it causes the twitch reflex that begins to break the cycle of pain.
So nothing's injected?
Nothing's injected. No, just a needle. It says here, trigger point dry needling is not acupuncture. Trigger point dry needling is based on Western medical research and principles. Acupuncture is based on traditional Chinese. The same type of needle is used for both procedures, but other than that, the two procedures are very different in methodology and practice. So if you're a provider, you might look into dry needle injection. They pimp it on the radio where I live. I don't know what it is. Drug delivery devices. I'll show you a picture of this, but now there are 6 new add-on codes where when they put things in your body that deliver medication, they also have some codes for removal. I found one where a person had some problems with their femur, so they inserted this nail that's covered with nanoparticles, and the medication released itself in there to cure these abscesses and necrotic bone. So, not sure that this is something that you'd ever use, but this is a fairly substantial intermedullary needle, and these are the screws that are holding it in place. Probably won't ever use it. Again, I don't see any big advancements in healthcare that require a lot of new coding. Anybody in thoracic medicine here? There's a code now for chest wall excision. Got a picture of it. So if you ever find yourself with a chest wall tumor, you go in there, crack open your ribs, and take that tumor out. There you go. There's this picture of them removing the entire chest wall for a tumor, probably metastatic. Anybody in ENT? All right. They have changed the nasal sinus descriptions. They moved the semicolon. It's a nerd thing to do, but anybody here ever had balloon sinuplasty? Balloon sinuplasty? They tried to sucker me into doing this once. They go in here and to open up your sinus cavities, they insert a balloon into like your maxillary sinuses. They basically have taken these codes and just broken them up into the actual sinuses. They go in there and they inject this, blow up that balloon just kind of like angioplasty, and it helps drain your sinus fluids. Now, I called one of my ENT friends and he said I got something that you're not supposed to use a lot. Some kind of nasal spray that you're not supposed and he told me how to mega dose Afrin myself without killing myself. And it worked. It cleaned me out real quick. What did I do? Oh, I don't remember. That was a couple years ago. I don't remember anything. But I had to do it several times throughout the day for like 2 or 3 days. But he said, you got to stop because if you keep using it, it'll mess you up. So, but I sent him my CT scan. Here's what the codes are going to look like. You see here they have maxillary, frontal, sphenoid. That's all. I mean, nothing big, but I have to do this just in case there's somebody who's in otolaryngology here. Pericardiocentesis has a new code. It basically has been rewritten to show that it includes imaging. I hope so. I mean, I don't know. I don't inject a needle into the heart or the tissue around the heart, but I would hope that there's some imaging. You ever see that commercial where have you ever worked with Dr. Jones before? Yeah, he's okay.
Yeah.
Just okay? Just okay. Yeah, but it's my heart. Is that okay? They a few years ago came out with a no lead pacemaker code. Okay, so like 2-3 years ago, they came out with a code that I taught you guys about, a no lead trait. So it was kind of, they made a pacemaker like a triangle over your heart, so you didn't have to have any leads. So it would make sense that, a couple years have went by. Now they had to come up with a code to remove those. Yeah. So pacemaker removal, it includes imaging. Most of these new codes just include imaging. Here's a picture of it. Removal of a pacemaker and retained surgical sponge. I don't understand that. It's probably not good. Have your probably. Oh, I like aortic arch graft revisions because those are the prettiest pictures in CPT. But the top of your heart, you have your aortic arch, and the ascending aortic graft codes are replaced. They've got a couple new codes. This is what it looks like, basically, an aortic arch revision. You see this? This is all like gross and stuff. Can you imagine walking around with that? Every time you get heartburn or something, you're like, oh my God, this is it. I'm coming to join you. It's just, I can't imagine. But again, nobody here is probably dealing with that. Or is there any vascular folks here? I go see the vascular surgeons I work with on Tuesday, and they have some new codes for endovascular repair. Now, this is the one time where I saw what we call a Category 3 code get to grow up and become a Category 1 code. So they took O254T, which is an iliac artery bifurcation endovascular repair, and they gave it its own Category 1 code. Here's kind of what it looks like. So people who have these aortic aneurysms, they rewrote a bunch of these codes about 2 years ago. You used to just have a couple for a pseudoaneurysm or a real aneurysms, and you build these based on whether or not you put them in the iliac arteries or you just leave them in the aorta, or if they go, so they have uni-iliac, bio-iliac, and then this is just an iliac branched endograft code, which nobody here would probably ever use. Also for vascular, there's codes for arterial exploration now. You still have 35701, but it'll change to carotid only to cover any neck artery with carotid. I think they also have upper extremity and lower extremity codes. Femoral and popliteal. Yeah. Without surgical repair. Here's a good one. Hemorrhoid code changes. So they got a new code for hemorrhoidectomies. Now, ironically, while most of the coding changes add the word with imaging, hemorrhoid codes are going to be changed. They'll have the phrase without imaging. And there's a new code for transanal dearterialization of 2 or more hemorrhoid columns or groups, including the ultrasound. So here's your new code. There's hope for all of us who have hemorrhoid, not me. I don't have hemorrhoids. And that's called a THD. And here they go. So they insert the Doppler ultrasound in there, annualize or tie off the hemorrhoid, and then they fix any prolapsed or hanging tissue. It's just a new code if you do hemorrhoidectomies. Tomorrow I'm at the Georgia OBGYN meeting, and here's their big change, which they probably really wouldn't use, and it's more of a trauma code, which is pelvic packing. Don't ever Google that. Don't. It's I have seen ISIS videos that are less traumatic than pelvic packing. But every time one of these codes comes up, I have to teach the CPC course, right? So I still have to understand at least 1% of what these are. But this is a pelvic pack, an example of a pelvic pack. Yeah. And the pictures are, most of them are traumatic motor vehicle accidents, and it's just not good. I'm happy to be on this side of the operating room. Anybody in urology? Hey, see, I said there'll be 4 things. Do you guys do orchipexies? You do. Okay, so let's go, everybody. Let's do this one together. 54640 has always been a source of confusion because it says with or without hernia repair, which is stupid, right? Because why would you just with or without hernia repair? CPT guidelines instruct you to report the service separately for inguinal hernia repair performed in conjunction with the inguinal orchipexy. The 2020 code keeps the guidelines to report the services separately and clarifies the description by removing the hernia repair. So if you do an orchipexy with a hernia repair, you get to bill both. And if you don't know what an orchipexy is, the word pexy for us coding nerds who aren't medical means surgical fixation. So they take the undescended testicle and they surgically fixate it down here. So orchy's the term for testicle. So, yay. So no big change. They just took out the word with or without hernia repair. Lumbar punctures. You're still, if you have a kid who's ever had a lumbar puncture, there's still 2 codes for that, but now they have a couple more codes for lumbar punctures under fluoroscopic or CT guidance. Really exciting stuff. So I found a picture of this. And don't answer this if you're a healthcare provider, but it's kind of interesting. Here's something you can learn about the spine. You have 7 cervical spine because that's when you eat breakfast. This is 7. You have 12 lumbar spine because that's when you eat lunch, and you have 5. You have 12 You have 12 thoracic and 5 lumbar because that's when you eat dinner, 5 o'clock. So 7, 12, and 5. If you take one of my coding classes and I'm not sick, I'll teach you that because you have to know when you're doing lumbar laminotomies, laminectomies, fusions. You have to know 7, 12, and 5. So this is the inner space between L3 and L4 here. Just nerd stuff. I've got to write an article on this for pain management. Any of those guys here? All right. The nerve destruction codes for the SI joint and genicular nerves are going to get 2 additional codes. So since, a lot of people don't know, there's your genicular nerve there. And then here's some of the changes. If you get, again, I'm sitting here before we started today just looking. I've got to write an article on this because my 3rd largest client is the largest spine and pain center in the country. And there's 7 or 8. Oh, my God. This is my Saturday. This is my Saturday while my wife is out. Maybe I should go run instead. Yeah, so I've got 15 pages of changes to these codes. They're basically making these nerve coding is really hard because some of the codes will talk about the initial nerve and then there are nerve branches. But they changed the wording on a lot of these to be more specific. And just about every code from 64400 on has changed. 64400 to 64451. Two new codes were added, 4451 and 4454. They've got some add-on codes, multiple regional blocks. They changed some of the headings. This is basically, it's not, there's 15 pages, but this is what the new stuff looks like. Nothing special. Doctors will just have to learn it, and nerve doctors don't like change. Pain management guys don't like change. There's a trigeminal nerve injection. Nice, huh? Ouch. Yeah. Be thankful today, yeah? Eye doctors. A lot of times people with diabetes will have retinal problems, and in the old days, well, still to some degree, I worked with a doctor who did retinal drawings. Here's a picture of a retinal drawing, and we bring them in at the end of the day, and the doctor would literally dilate your pupil and look at your eye and draw pictures. And it's fairly common. It's a very audited code, but they changed some of those codes. They changed some cataract codes. Cataract, the big thing with cataract is the term phacoemulsification. If you have a mother or a grandparent who has cataract surgery, they'll have this code 6. It's one of the most costly surgeries in the Medicare. It costs the government a lot because everybody gets cataract, apparently. But those codes will now read without cyclophotocoagulation. And that's because of another change they've made. But here's a picture. I mean, they make an injection in your, not an injection, an incision into your lens. They go in there with like an ultrasound machine, crack open your lens, and they crack open all that hard stuff and suck it out. That's phacoemulsification. Now, what this new code does is your ciliary body helps kind of with glaucoma and pressure between the front and back part of your eye. So they have this new code for ciliary body cyclophotocoagulation endoscopic. It's nothing. I mean, if you're even if you're in ophthalmology, it's nothing. Just added a couple words and added a couple codes. But there's your eye anatomy there, little cross section of your anterior and posterior segment. Next section is totally boring. ER, sometimes you go to the ER, you have an abdominal x-ray. You remember, I think it was last year, they changed all the chest x-ray codes. It used to be 71020, and then it became 747. Well, there was a code that we use in the ER all the time that included a single view chest x-ray and a couple abdominal. There's an abdominal series with a single view chest x-ray. And they just changed that code now to read 2 more views of the abdomen. Not a big change. The biggest change in the radiology section came to GI x-rays, which again, most of us wouldn't use. Pharynx, cervical, esophagus codes and swallowing study codes have codes now that are contrast studies. Esophagus now. These codes say that they include a scout x-ray, which would be an initial x-ray prior to the procedure being done. That's the major change. Doctors wanted to bill for 2 x-rays, and they said, well, no, the first one's going to be bundled into the second. That's all. They made some change to the small intestine codes for x-rays, which, again, most of us would never deal with. Colon x-rays, again, and just include the scout abdominal radiographs and delayed images. Don't worry. They have to deal more with these barium enema codes. So, one of the preventative benefits under Medicare is you can get a screening colonoscopy. You can get Cologuard now. You can get a Hemocol, or you can get a barium enema. So I always wonder what a barium enema looked like, and there it is. Is anybody here on Twitter?
Yes.
Twitter has some really cool, there's a group of people who are, they're called medical students. They're a really interesting group. But they publish a lot of really cool stuff. If you're interested in learning more about anatomy, physiology, and if you're on Twitter, you might as well just, go out and find some medical students to follow. And they publish all kinds of really cool stuff like this. I get a lot of these pictures from Twitter. I just, screen cap them and send them to myself, and yeah. Cardiology, folks. I mean, most of the time, when you guys order a nuclear stress test, you do a 78452 and a 9301. Okay. So they've added a bunch of codes for nuclear stress tests that include SPECT or PET scans. So like here's what a SPECT looks like. You see how it's a little blurry, and apparently PET scans are a little bit more crisp. So I don't think it's going to impact you guys at all. But the descriptor for the existing PET metabolic evaluation 78459, which includes ventricular wall motion and ejection fraction when performed. So you guys might want to just look at 78459, and there's a new code 78429 when a CT transmission scan is. Your doctors are still going to just order nuclear stress test, 78452, 93015, and if you do them in the hospital, you do your 7845226, 93016, 93018. But there might be some doctor at the hospital who wants to try to start doing some new stuff. So, I would go to the 78452 codes, look in your CPT book, show them to one of your doctors, and just say, hey, listen, is there any chance that you would want to order one of these? I'm not even sure the hospital would have this equipment. Yeah, your hospital's pretty fancy. They might have this stuff. but it's for these PET scans and CT scans that you're used to doing for your nuclear study test. Nobody here would use this, but it's radiopharmaceutical localization of a tumor. These codes that I'm talking to you about now are in your CPT book in the 78,000 series, and that's where all the nuclear medicine stuff is. So, but nobody here. My daughter studied nuclear physics in college, and that was an avenue for her, and Dum Dum didn't take, well, she's not. She's probably going to listen to this, but she didn't take it. But they offered her jobs at the hospital working in, the nuclear medicine department. So she had all kinds of awesome jobs lined up, but she's a Generation Y person. You listening to me back there in the yellow jacket? So what did she do? She took the job to help people, not to make money. What do you think I should do, Dad? I said, make as much money as you can, bank that crap, and then near the end of your life, go help teach. Bank, baby. You're not going to go to Paris on a teacher salary. You work at SRS, you can go every month if you want to make some real money. But no, she had to change the world. She reminds me of that little 16-year-old girl on the boat talking about the world ending. Elsa. You know what I'm talking about? I can't believe you have me here. I should be in school. Nobody's stopping you. All right? Look at you. Look at me now, judgmentally. I don't care. She's 16. Thank God I wasn't allowed on TV to think about what I was thinking about when I was 16. What was it? Remember what you were you concerned about anything when you were 16? When I was 16, you know what I liked? This will show you how I'm not real old, but I used to think Madonna was like making a statement when Papa don't preach. And I was like, she's totally speaking for my generation. And then they interviewed her and she was just a dum-dum. It's like, but I used to think that like Madonna was changing the world. I'm 51 and I was like, Madonna, she speaks for my generation. And then they interviewed her in a convertible on MTV and talking about guys. And I was like, oh God, what am I doing with my life? Worshiping these people. They're all idiots. I got to get a job. Neurovascular codes. You ever have to refer a patient for hemodialysis access? Anybody? Or dialysis? No. They came up with a couple codes for doing blood flow studies prior to getting hemodialysis. So this is an arteriovenous fistula here. There are specialties now. There's interventional nephrologists who their whole job is just to keep those venous access ports open. Yeah, it's really kind of cool. Interventional nephrologist. What a job. What a job. I'm telling you, what a job. 9 to 5. Are you kidding? Big money. Couldn't we all do some of this right now? Physical therapy. Look at that candle picture there. Therapeutic intervention focusing on cognitive functions. So, occupational therapist, physical therapist, trying to make a change in cognitive function. And it came up with a couple. Anybody here build physical therapy? None of my physical therapists that I work with physical and occupational therapists who deal with children. Because one of my hospital clients is they have the Anna Shaw Center. They work with children with severe mental and neurological deficits. So, but I thought this was kind of a cool picture of your brain and where all the different things come from. That if you don't know, I don't know. I have to learn this stuff in school. Here's all your vision is in the back, and so hit me in the back of the head when I do something wrong doesn't help. So I can't see. It's just stupid. New flu shot. Listen, here's my thing for flu shots. Everybody in this room's giving flu shots. I know you know to do this, but go grab the bottle of flu from the nurse. Just make sure you're using the right code. I still come across doctors who are billing a $15 flu shot code, but buying the $40 shot of flu. You know, because the coder just doesn't walk back and say to the nurse, "Hey, let me see the flu." You know, they'll say to me, "What flu shot code do I use?" And I'm like, "I don't know. There's 20 of them. You got to tell me what the medicine is." Well, how do I know? Well, ask the nurse. Thank God I get paid in 15-minute increments, right? It's just ridiculous. Just ask somebody. Perianal muscle biofeedback training. Again, may you never have to have this problem. They deleted the 90911 and now they have codes for each additional 15 minutes. Again, do not Google the perianal region if you don't know where it's at. Just trust me on that one. Anybody here have audiology that you code for or bill for? All right. Well, they came up with a couple new codes for doing that. Again, if you do this, there's posturography and auditory function. 92548 and 92626. If you're into that world, just turn to those two codes. And evaluation of auditory function for surgically implanted devices or postoperative status of surgical. That's the one that I probably think would be used the most in the 92626. For you guys in cardiology who do echoes, there's a new code 93356 for speckled tracking delivered assessment. Speckled tracking delivery assessment. Again, I know none of my clients have said that that's something they're interested in, but you know what? I still show it to them. That's my job. I don't know what this stuff is. And if you want to use it, if the doctor says, yeah, we do that, man, that's really good. There's a code for that. Then I just add it to our charge sheet. Check the fee on the Medicare website when it comes out and add it. So, look at me. I stretched that out for about an hour and a half. I did good. With your initial speaker, we're at 10:30. We talked about the big changes, right? No money, 5-cent raise in the conversion factor. I told you how to get in touch with QPP, right? Big thing to do is call your vendor. I don't know. Linda and I are doing some stuff over next year. It's called, I think, Coding Coffee with Steve. I mean, it's possible that we can I might learn something about QPP and we can spend 15 or 20 minutes talking about it. But before you do that, just make sure to know that it's not the end of the world, but you got to do it because these points keep going up. This is also the reason, that these ACOs are starting to grow. We're going to take a break in a little bit and come back and talk about the E&M codes, all those changes. I'll get you up to date to where you are now and then show you what's going to happen in the future. Because you'll probably really need to hear the E&M stuff 2 or 3 times. And at some point in time, Linda's going to have me come back and we'll do an evening talk for physicians, probably near middle of the year or end of the year. And then so we can show the doctors because there's going to be a substantial change in your coding profile. The new guidelines are easier. We looked at the surgery changes, the radiology sections, which again, for you guys, that's mostly the showing the doctors these new radiological options to see if there's anything in there that they want to order for spec testing for myocardial perfusion studies. No path changes really significant for lab work that you order. And then in the medicine section, again, just a new flu shot code that you might look at if you're interested. So that's it, man. Do you guys have any questions? And if you do about any of the codes that I went over, I have my CPT 2020 coding change book up here. Like I said, it just came yesterday. And I bring it with me today, tomorrow, and next week I do Nancy's. Just in case you have a question, we can look up something together. Okay? You guys have anything for me? Did you think you'd get through that? Hour and a half of happiness? All right. Now, while you're sitting here, let's make sure that I turn this off correctly. Let's see. All right. All right. So here we go.